right, good afternoon, guys. First of all, I want to apologize for running a little bit late. Of course, when you're in the hospital, things don't go according to us plan as we like it to be. But we are here, episode 57 of Lunch Learn with Dr. Pierre. I'm your host, yours truly, board certified internist, founder of drpierreblog.com, as well as your host of the Lunch Learn with Dr. Barry, your number one podcast for patient advocacy and helping you empower yourself for better health. Right. So now that we got those introductions out the way again, today we're going to have a very interesting live stream. Again, it's going to be one where we try to do some education. We're going to be talking about hospice care, and I know it's a subject that we don't necessarily like talking about, right? Which is, just end of life and death in general. But it's important, especially being in the hospital setting and all of the, the ramifications associated with just the fact that you're not guaranteed to walk out the hospital, right? And in that sense, right, so I tend to talk a little bit more about death because I want you to be more prepared about the subject in general, right? So we're going to just share this real quick. If you have a chance, go ahead and press the share button on your own, and we'll get these things started. Like I said, we're not going to do it too quick. I usually like to leave these lunch and learns about 15 minutes or so, right? Because again, I know it's video, right? So we want to try to keep your attention for as long as possible, but we want to try to give as much information as we can before we go. So let me just do my thing, press a couple, share as needed. And it's weird because especially with some of the changes that Facebook has made, I can't really, especially for your personal pages, right? Like I have a lot of people who follow me for my personal page, but you can't really post to your personal page like you used to be able to. Let me just do this real quick. All right, so that is share. Oh, I forgot one more page. One more. Believe it or not, I'm actually going to be getting a lunch and learn. So, 57. All right, so again, I hate to do that little prelim work, but you gotta do what you gotta do, right? So if you have not had a chance, check out the recent episode 77 of the podcast. This is episode 57 of the live stream, right? But check out episode 77 of the podcast, where I asked the question, what is hospice care, right? And the motivation behind wanting to do a podcast of this episode, right, is because if you don't know about the, spill the beans, right? Like Aretha Franklin, she was recently placed into hospice care last week. Now, of course, at the time I was recording it, she was still in hospice care. As you know, now she did pass away, so rest in peace to Miss Aretha Franklin, an amazing person, amazing singer, right? And the reason why I wanted to do it, right, is because, I saw it posted on one article, one blog site, and immediately I saw comments, right? Comments that clearly did not know what hospice care was, right? And just saying, the family's trying to push her out, and family's trying to get rid of her and make her, which is totally false. But it has always been this, misnomer, right? This misconception associated with hospice. And being that I come from outpatient medicine, and now I'm doing a lot of inpatient, well, mostly inpatient medicine, right? And seeing both sides of it, right? And seeing really the importance of, having that discussion with family. In fact, as we speak, today I just had a conversation with a family, right? Like, when I was recording the podcast, I said that I had a week where I had 4 of my patients going to hospice therapy, right? Like, that number has already gone up to 6 since I recorded the podcast, right? And this morning I had a conversation about it, right? It's something that I tend to have a lot more than I can. Now, of course, that doesn't mean that all of my patients are going under hospice therapy, right? Like, again, I take care of lots of patients, right? So it's a very small percentage, right? But the ones I do is definitely something that I try to champion and, get hospice involved early, because I understand the ramifications of, not having a good plan at the end, right? I understand the ramifications of not having the needs and equipment, and really just kind of being lost, right? Especially for my caregivers, right? In the podcast episode, I talk a lot about why not only is hospice important for the patient, right, but really important for the caregivers, those who are, having to address and take care of all of these patients who are sick and or who are at the end of their life, right? So when I was doing my, my Googling, right, when I was doing my research and just trying to, give you guys a broad definition of what is hospice care, right? A very common theme that I saw with a lot of the different hospice organizations, and even local and national, right, is because a common theme was like the quality of life, right? Like a big theme for them, right, is like, how do we improve the quality of life for this person right here? And what tends to happen, especially in a hospital setting, I talk about how in the hospital setting, we'll do everything, right? We'll wake you up at 4 o'clock in the morning. We'll draw blood. We'll get vitals. We'll poke. We'll project. We'll do everything until you say, you know what? That's it, right? I don't want to do none of this anymore. And I have a lot of patients where all the stuff that we're doing, right, yes, it's prolonging their life, right? But it's not actually improving it, right? It's actually not improving that quality of life, right? And usually when you go to the doctor's office, right, when you get a cold, right, when you get some pain, when you fall, and anytime you go to the doctor's office, right, you're going to them because you want them to improve your current state of life. And unfortunately, you get to the point for a lot of your patients where that's not the case, right? Where you can do everything under the sun, right, and that does not help the patient. Like, I still remember, again, I haven't been practicing that long, right? Because I graduated in 2014, right? So again, a little 4+ years or so. So I haven't been graduating that long, right? But like, I know my first patient who I sent to hospice, right? First patient, I remember, was a nice lady. She came in, abdominal pain. I had inflammation in pancreatitis. And a family was like, yeah, you know what? We don't do this anymore, right? Because the treatment course just wasn't going as quote unquote planned, and her leg, when we treat one thing, another thing broke down, and you could tell the family was just like, you know what? She's lived an amazing life, and she does not want to have to go through all of this, right? Like, let's make her comfortable. And it was the first time I was introduced into that hospice care, right? I knew of hospice because, they taught us in medical school, right? They taught us a little bit about what hospice care was and what did you need to do for it. So I know a little bit above it, right? But like, it was my first experience hand in hand with a patient of my own that was going into hospice care, right? And as an internist, right, we think that we could save the world. Most physicians do, right? We think we could save the world. And here I did everything. I was a first-year medical resident. I did everything under the sun, and it still wasn't enough to save this patient here, right? And that's something that like takes you back a little bit, right? Because you're like, oh, I thought if I just, did A through Z and I pressed a couple buttons here and there and I ordered the right test and I did the right medications, right, that this person would be okay. And it's very telling when you do all of that and it does not work, right? And that for a medicine resident, just a resident in general, right? That's a realization that a lot of us come to, right? A lot of us come to the point where you can do all that you can and there's nothing else I can do for my patient here, right? And then when you get to that point where, there's nothing else I can do for my patient, this is where a service like hospice comes in, right? Hospice comes in and, depending on where you're at, right? Like I'm in South Florida, right? So we have, South Florida, right? So we have lots of people who end up on hospice, right? And in the old times, you used to think about hospice care with just cancer, right? Like it used to be like, if you got cancer, we're talking about hospice, right? But now in these days, right, like a study showing that the numbers are showing that more than 50% of people who are in hospice are not in hospice because of cancer, right? They're in hospice because of end-stage kidney disease, end-stage liver disease, end-stage heart disease, end-stage lung disease, right? Advanced dementia, right? Like they're HIV, right? Like AIDS, or AIDS, especially full-blown AIDS. They're in hospice for a lot of different reasons other than the fact that they have cancer. That's not to say that a lot of people who have cancer are not in hospice. That's clearly the case, right? The study reports came out after Miss Franklin died. That apparently she was diagnosed with pancreatic cancer, which is one of the cancers that it's very troubling, right? And again, I won't go too much in detail of pancreatic cancer, but it's definitely one where if you get diagnosed with pancreatic cancer, it's a problem, right? So here it was, you get this patient and you realize as the physician, right, like there's nothing else I can do, right, that's going to, one, help my patient, treat my patient, and most importantly, especially when we're talking about the hospice model, right, most importantly, improve the quality of care, right? Like if everything I'm doing is not improving the quality of care, I need to look into myself and say, you know what, should I continue doing what I'm doing, right? And I think for a lot of families, a lot of physicians, this is a very tough reality that they face, right? That like I am not improving the quality of care of my loved one. Like, so why do I need to keep doing this, right? Like again, I have a patient of mine, right? Like again, I'm an inpatient doctor now. I was taking care of this patient when I was an outpatient doctor at my old job, right? And now I take care of her here, and she's just not doing good, right? She's not doing good, and it's clear as day. Is like she's the quality of life. What I'm doing is not going to help her, right? She is one who would be beneficial for something like hospice, right? And she has an end-stage diagnosis that is not going to be cured, and all of the subspecialists are like, nothing for me to do here. So like I have to have serious discussions with the family, and I've had them. Like we're in the process as we speak of what, I think hospice is probably going to be our best bet, right? Because what we're doing right now isn't helping her. And I think that once you get to that realization, right? Once you get that realization and that turning point that says that, okay, all the stuff I'm doing is not going to help, but I still need help, right? Because again, this, like, I think when when the government last year or so, when they were talking about like when death panels was like a big thing, was like when that was like a buzzword on TV, the death panels. A lot of the issues was like just having this discussion, right? Like people, the physicians, right, and families, and the politicians, right, for some reason did not even want us to have these type of discussions with our patients. Like, hey, whatever you do may not work, right? And because it may not work, like we need to come to type resolution, right? And this is where like hospice, kind of comes in and kind of swoops today. And it's not a thing that's been around for a long time, right? It's only been since the 70s. So since the 70s is when we really started hospice care. And at first it was all about the cancer, all about the end of life, and then they started really expanding it when they started realizing like, no, my services would benefit a lot more people than just the people with cancer, right? And you have services including physical therapy, occupational therapy. You have equipment, walkers, beds, things that can make you comfortable. You can do hospice in your home, right? Again, I think that's something that people don't realize. I know a lot of people say, you know what, I don't want to send my family members to a home because I don't want them to pass away in a place that they're not used to, right? Like if your family member qualifies for hospice, they can do this inside your house, right? Like, yeah, this is something that, again, their goal is to improve the quality of life, right? The patient's life, the caregiver's life, right? And I really want to stress the caregiver because, and again, if you go check out the podcast episode, in fact, I'll put a link in. I'll put a link in the comments. But the caregivers, right, and this is something that I've talked about a lot, right? The caregivers who's responsible for taking care of the patients, they need just as much as help, right? They need just as much counseling. They need just as much, mental and physical support as well, too. And a lot of times they're the only ones, right? I've been taking care of patients where it's one family member having to do everything for the one sick family member. Right. So now this one family member who has to do it all there's no way they can take care of themselves, right? There's no way they can take care of other things that's important to them because all of their attention is devoted on their sick relative, their sick person, right? The sick person they're taking care of. And that's where, something like hospice comes in and says, hey, you know what? We can give you a break, right? Like we can say, hey, you know what? For 8 hours or so, just do you for a little bit, take care of you while we take care of it over here, right? So, and those are just some of the different services, right? Hospice has a lot of different services, and it's not like you're being taken care of by like nobodies, right? The same people who take care of you in the hospital, physicians, nurses, occupational therapy, physical therapy, speech, like the same people who take care of you there are in the hospice, right? Like it's not a downturn in care, right? Where all of a sudden, all right, no one. They kind of put you in the corner and no one knows or talks to you, right? That's not the case, right? They just say, you know what? All of those, that chemotherapy that you're doing, it's not helping, right? The fact that you're having trouble breathing, the fact that every time you go to dialysis, you're so tired that it takes you a day and a half to recover, and by the time it's a day and a half to recover, you're already thinking about the next time you have to do dialysis, and you're like, you know what, you're done, you don't want to do dialysis, right? Like that's where services like hospice comes in, because it understands that you've gotten to the point, right? You've gotten to the end point that you're like tired of doing it all. You're tired of doing the treatment because it's not going to help, right? It's not going to help in the long run, right? If it's not going to help in the long run, you're asking yourself, why do I need to continue to do it? And I think that's why I want to make this discussion of hospice, right? Like we've talked about on the Lunch and Learn, we talked about a podcast before. Just having the discussion with your doctor, having the discussion with your family is all important, right? Because again, nobody, this is a topic that nobody wants to talk about, right? Nobody wants to talk about hospice, right? Because to talk about hospice, you got to talk about death, right? And we know we don't want to talk about death. And again, now I'm not saying this is just a patient issue, right? I got a lot of physicians who don't like talking about death, right? I got a lot of physicians who are saying, they'll follow up later, right? I got a lot of physicians who are even residents. One of the things as a program director, one of the things I'm teaching my residents, teaching my interns is how to have that conversation, how to be comfortable. Because if your physician isn't comfortable having a conversation, there's no way you're going to be comfortable in accepting, right? You're not going to be comfortable in accepting, you know what, I may need help. My mom, my dad, my uncle, my brother, my sister, my child may need to go in hospice care, right? You're not going to accept any of that, right, if the physician isn't comfortable telling it to you, right? So again, those are just some of the things here. And again, I go into a little bit more detail on the podcast about some numbers as far as in regards to who's in hospice, who's taking care of hospice. I talk a lot about the caregivers, who's taking care of who. Again, I'll just quick facts here. Let me see, 66 million people are providing care for someone who's sick, right? 66 million people. 43 million people are taking care of someone over the age of 50, right? 40 to 70% of caregivers have depression. Like, think about that, right? Like, we could probably stop this video right here, right? And for my caregivers, right? For those who are taking care of someone who's sick right now, 40 to 70% of caregivers are depressed. And they're usually depressed because, one, they can't take care of themselves. And the two, they're having to take care of someone they probably can't take care of anymore, right? So, and again, they deal with stress, blood pressure issues, anxiety, depression, exhaustion, sometimes some alcohol or drug abuse associated, and really they just neglect their own selves. So again, I just wanted to touch this recap this week. Again, Lunch and Dr. Barry, we're back here every Friday, and I either try to do a recap of the podcast episode this week or we do a new topic. But I think with the recent passing of Miss Aretha Franklin, and the fact that she was in a hospice, and she wasn't in a hospice for a very long time, right? Which isn't surprising. I think a lot of people before used to think like, oh, if I'm not going to pass away within 6 months, I'm not eligible for hospice, right? But that's just not true. Like, there's a lot of different criteria to meet hospice, right? So I'm gonna put a link to the show notes from episode 77. Check that out. Check the podcast episode out if you have not had a chance. Make sure if you already subscribed, make sure subscribe to the podcast. Much appreciated. Lunch and Learn with Dr. Barry podcast, 5-star reviews. We're talking about hospice care, and I'm gonna see you guys next week. Bye.